Hello, we are here live from the 12th Congress of the World Federation of Pediatric Intensive and Critical Care Societies. I'm Tracy Walbrink, the Education Chair for WFPICCS, and I'm really excited. We're doing our live session for the afternoon here, and I'm joined with Dr. Robbie Kamani and Helen Mercer, and we're going to be talking a little bit about some of the activities that are going on today. Dr. Kamani is, if you don't mind introducing yourself, where you practice, who you are, and you've been doing a lot of talks, plenaries, and other sessions, so I'm hoping after you introduce yourself, you can tell a little bit of what you hope people are taking home as best strategies for mechanical ventilation.
Sure. So my name is Robbie Kamani. I'm a pediatric intensivist at Children's Hospital Los Angeles, and I do a lot of research in pediatric mechanical ventilation. And I've done work with the PALIC, the Pediatric Acute Lung Injury Consensus Conference Group, and the Ventilator Liberation Group. And in fact, that's been the focus here, is to sort of talk about some of the ventilation strategies we may consider within ARDS, as well as ventilator liberation. I think some of the themes that have emerged, especially as talking to the attendees and looking at the questions that they're asking, relate to some of the monitoring we might do for patients on mechanical ventilation, especially as it relates to this idea that although we have patients with acute respiratory distress syndrome, we don't manage all of them the exact same way in terms of our ventilator choices. So we can still personalize our ventilator strategies to account for differences that each of these patients have, this heterogeneity concept that patients have. And that heterogeneity can be captured by looking at some of the parameters, that we have on the ventilator. So I think some of the themes that have really emerged is this idea that the tidal volume does not have to always be 6 mLs per kilo, that we can and should apply a patient-specific tidal volume within that range of 4 to 8 mLs per kilo based upon what the demands are of that patient. So 6 mLs per kilo might be right for a patient who has reasonable compliance and you can achieve driving pressure and plateau pressure limits. If the patient does not, or the patient has higher drive, then we might need a lower tidal volume for that patient or a higher tidal volume for that patient to account for what it is that they need if they're breathing spontaneously or if they're not, based upon their compliance.
Yeah, that's great.
I think the other real theme that sort of emerged today had a lot of discussions about plateau pressure measurements. And plateau pressure measurements have sort of commonly only been used in volume control ventilation, but the reality is that the plateau pressure is really the only way for us to understand what's happening at the alveoli, to understand that alveolar pressure. And it can and should be measured, I believe, on every ventilated patient every day. That's what I do in my practice, because it tells me what is that lung actually seeing. And we can have a plateau pressure that is the same as the peak pressure. It can be lower than the peak pressure, but when patients have vigorous respiratory effort, it in fact can be higher than the peak pressure. And that's something important for us to capture to know what the lung is truly saying.
I wonder if you might just kind of walk through the steps. There's a lot of trainees that are attending here, or people that aren't normally measuring plateau pressure. So how do you actually do that on the ventilator?
Yeah, good question.
Especially with spontaneously breathing patients.
So it depends on the ventilator that you have. Each of them has a slightly different way to do this, but fundamentally what you're doing is an inspiratory hold on the ventilator, right? So the patient takes a breath, and you can do this in supported mode, like pressure support. You can do it in a controlled mode, like assist control. You can do it in SINV, the hybrid mode between the two. It's about picking the breath if you're in SINV, which becomes a little bit more challenging. So when the patient starts to take the breath, or the ventilator is starting to deliver the breath, you push and hold that inspiratory hold button. The ideal hold should be 3 seconds long. However, it might be adequate even if you get a 1.5 to 2 second hold. Oftentimes you can still tell the information that you need. And then you look at the plateau on the screen. So you're looking at the airway pressure on the screen, and you want to make sure it's flat all the way across, right? It may change at the very beginning of the breath as the pressure starts to equilibrate, but eventually it becomes flat. If it's flat, that's a valid plateau, and you can use it. You can take that value. Generally, ventilators allow you to scroll back and forth to find what the exact value is for that plateau pressure. That's your plateau pressure. And you look at the PEEP value, and you look at the difference between those two to calculate your driving pressure. What's important is that you have a true plateau. And there are some patients, especially patients that are breathing spontaneously, that might have high amount of drive, where you can't get a real plateau. The pressure is rising, the pressure is falling, You're seeing them trying to take a breath in between, so that's an invalid plateau, and you should not rely upon that.
And so you should just keep trying until you get a good straight waveform.
Yeah, or there are some patients where you truly can't get it. There are other things you can do for those types of patients, expiratory occlusion maneuvers to get an estimate, but about 75% of the patients you can generally get a reliable reading.
That's great. And the other thing you talked about a lot yesterday was driving pressure, and I know that's been a big emphasis of the new guidelines. And I'm, curious if you want to just describe a little bit why is driving pressure so important?
So it's a very good question, and it truly has not been definitively answered in pediatrics if driving pressure is the right variable. I will also say it hasn't been definitively answered in adults, even though that's still the most touted pressure to be using. So the adult data is really based on secondary analysis of a number of RCTs that have been done that have shown that the driving pressure seems to have almost a linear relationship with outcome, and that a driving pressure threshold of 15, when it's exceeded, seems to be associated with the worst outcome in the randomized trials. The adult world is now engaging in the DRIVE clinical trial, which is a driving pressure targeted clinical trial, because there is still a bit of a leap to say the observational data or the reanalysis of RCTs, highlights higher driving pressure versus outcome. If we try to target a specific driving pressure, there may be some unintended consequences of what we might have to do to keep the driving pressure below that rate. Sedate, paralyze that patient as an example, right? So it really does need an RCT. Adults are embarking on an adult RCT. We probably need a pediatric RCT as well to know whether that's really the right threshold to use. But conceptually, I think it's an important point to say that we should be monitoring and looking at the driving pressure. And when that driving pressure is high, over 15 centimeters of water, we should pay attention to that in that patient and think that patient might need some change in their ventilation strategy. Maybe we try to recruit them by giving them more PEEP. Maybe we should sedate them, right, to try to bring that down. But I am also not necessarily truly dogmatic about 15. Right? It's staying somewhere close to that threshold because we think that when it exceeds that threshold, there's a higher risk of harm. But you have to individualize this, I think, for your patient.
I think you showed us that very nicely with your examples yesterday in the plenary session, how similar settings, similar variables, but the patient's compliance and respiratory factors are so different. And nothing comes for free. Sedation, paralysis, tidal volumes, all of these things are challenging, and so matching those individually, I think, you mentioned that in your very first statement, I think is the right thing. So thank you so much for sharing your insights with us, and I hope you have a safe flight home. I know you're off.
Pleasure being here.
Wonderful. Well, thank you.
Thank you.
Nice chatting with you.
You too.
Perfect. All right. Hello. All right, and now I'll give this to you.
Thank you so much.
Thank you. All right. I'm here with Helen Mercer, who is a physio, and I'm curious if you can say who you are, what you do, where you're from, and then I'm going to ask you, what are you excited about in this conference? What are a few things that have been highlights for you? What are some things that you might be looking forward to? And also, if you're an allied health professional, what has really come out and emerged as a great topic or a great session for you?
Awesome, thank you. So I'm Helen. I'm one of the specialist physios at Great Ormondale Hospital in London. I'm also the clinical lead for neonates at St George's, so a bit of a mixture. Here with WFPICCS today, mostly to take in some information about new ventilation strategies. I did my ventilation practitioners course, so picking up anything from that, a really lovely lesson there from Rob, and that we've just learned as well. Bringing some colleagues with me as well, so the main thing we've been looking at today and yesterday was early mobilisation, PICCU liberation. There was a great talk yesterday by Ali Ferguson about her study on that on PICCU stars. I know Emma's talking later on a specific case we had about early mobilisation on ECMO, which is really interesting. Some other colleagues doing systematic reviews on physiotherapy management. Someone made a really key point recently at a conference that often physiotherapists feel like invited guests rather than part of the team. So lots of team working talks yesterday. Adriano spoke about occupational therapy in the unit as well, which I thought was really interesting to hear. But also like how we can congregate as an MDT and be part of that practice. I brought a case myself, which was a really complex, challenging spinal cord injury patient. And I wanted to sort of show to the world about how we can help and support our team, and how we can guide using the expertise of myself and my colleagues with a specific case to look at like holistic challenges. The World Cafe this morning that was led by Debs and Hani about delirium and how that can impact your practice was really fascinating for me about the early mobilisation. Ours at Great Ormond Street is called Gosh Go, and so many things we think about, and actually little nuggets that she gave this morning, you know, encouraging parents to use Play-Doh with their children is something I'd never really considered. But actually think about that positive sensory that we use in neonates, actually equally as important in PIC that I've not really thought of before. And then I think the next study for me, I'm really interested in neuroprotection. I think the spinal cord injury as well really showed me that. And the next session I'm going to go to is about the neuroprotection and the management post resuscitation, which we see a lot of. So I'm really excited for that to come up now too.
Fantastic. Well, tell us a little bit about the presentation that you're going to be giving, the case that you're presenting.
So the post presentation I've done is called the holistic challenges of the pediatric spinal cord patient. It's a patient whose family very kindly have shared the photographs of him and allowed us to share his case with the world. So he's a 12-year-old who presented with headaches, turned out to be a medulloblastoma, and 12 hours post-resection had sudden loss of power and was found to have a C2-3 spinal cord infarct. So he presented to our unit, fully aware, fully conscious, but no respiratory drive, no power. It's a really challenging situation for the parents. And we're so not used to using spinal cord injuries in our unit. We're not a trauma centre, we're a neurosurgical centre. And I think from a learning perspective, understanding how the complications of spinal cord injuries really impact on rehab. So autonomic dysreflexia wasn't managed before, no education on that. Ventilation strategies or learning on how not to wean. All of the studies are in adult studies. And I think as paediatric therapists and as a community, we found that really challenging to have a real lack of support. So our emerging themes is how can we create this spinal cord network in paediatrics in London. And it's something we've started from it. So it was a case that taught us a lot, used a lot of our emotional power. I think we got quite burnt out from it, which I think is really important to highlight as a team that it was a really challenging situation and how we move forward from this.
Well, that's wonderful. Hopefully people will come and learn even more from your case presentation. Well, and I think you're highlighting such an important thing. We're a team. You know, no one of us could do our jobs in isolation, and so I think it's really beautiful at this Congress that we've been highlighting just the work that each contribution makes to the whole patient care opportunity. So thank you so much for sharing your perspective. I appreciate it. All right.
Thank you so much for
having me. Have a good rest of your conference.
Thank you so much.
Great. All right. And now I'm going to be here with Dr. Manuel Soriano, who is one of our organizing committee members. Thank you so much.
Hey,
how are you today?
Oh, well, I'm doing well. Really, I feel fantastic about the results of this Congress. Really, we were expecting that it could be a great Congress, but it has been more than we expected.
Wonderful. That's amazing. And it's just been incredible to see the sheer number of people from how many countries are here represented?
Well, we have many countries. First is Mexico because, well, maybe we are local. And secondly, we have United States. And third place is Colombia. So we have countries really from all the, wow, we have many countries on this Congress. And really, we're enjoying multicultural speech and multicultural, I don't know, these relationships that we are learning from every part of the world. Maybe sometimes people from other part of the world see Mexicans, hey, how are you? And you go, what's happening over here? But we're living those things. And I think that this is scientific moment, but it's a social moment too. And I enjoy that I can see people from all the world talking about it.
No, it's been fantastic. And the thing that's been highlighted so much with these YouTube live sessions have been the people saying the connection, being able to touch each other, being able to see each other, and it's just been a wonderful way to bring our community back together.
I don't know if I was most nervous about the scientific or the social, but everything is working so fine.
Absolutely, and we have all these incredible posters behind us with all this wonderful science, so it's really been an amazing conference. We've been able to talk with most of the plenary speakers, and we'll be interviewing the plenary speakers from today, this evening, so really excited. How about the party tonight?
Well, we have a gala dinner today, and we are going to know how is the people over there, because we were on a free manner, every people, and we can talk in not only science. We can talk anything. And while we have the gala dinner today, it's in front. It's going to be on the beach, and so I hope that everybody can enjoy this, because we're gonna have some demonstration of culture. We are gonna have some classical dances or some classical mariachi. Well, we have many surprises for you.
Yeah, that's wonderful. Well, I'm looking forward to it.
Yeah.
Anything else you want to highlight for people for the rest of the conference?
Well, I only wanted to say, I would like to say that thank you for everyone that has come over here. I know that Cancun is a difficult place to come because it's not cheap. For many people in Latin America, well, it's a high cost. Then that you made this possible, and really all the attenders really are fantastic because they made this conference possible. Really, thank you so much.
Well, thank you so much for joining us. I appreciate it. And thank you for all your effort in making this possible. It's been a wonderful Congress, and can't wait for the last 2 days.
Please enjoy this.
Thank you so much.
Bye.
Okay. All right. Bye-bye.
Bye.
Well, thank you, everyone. This has been great. We're going to continue enjoying the scientific sessions and meeting colleagues, and we'll be back this evening. Thank you very much.